time zone in the US?
Yes,
Oh, I see.
that occurred last week. Last weekend. Last weekend, the clocks were moved ahead 1 hour.
Okay, and this will happen again in October, I think.
Yes, in October the clocks will be moved back 1 hour. So it's a rather controversial, or somewhat. I don't know if it's a major controversy, but it's a somewhat controversial consideration in the States as to whether it's necessary to do these things or to move the clocks up and backwards and so forth in terms of daylight saving time, as we call it. So, but regardless of how one feels about it, the clocks move. We all had to stay in the same time, so we do it. So that's, I think other countries, do you move the clocks forward at all, Dr. Manopo in Indonesia?
No, we are still in the same time.
Right.
Maybe because of we are in the equatorial, yeah, in the middle of.
Yes,
So that's why I
right,
think there is no changing of the time.
right. Well, it's actually a favor for me because otherwise it would be 1 hour earlier. And as we did, you very graciously have invited me to participate in these various chapters. And so we'd be starting at 6 a.m. my time if it were prior to last weekend. So this is a break for me.
It's better this way, right? It's because
It is better this way. It's a little bit later in the morning.
yes. Okay. Excellent. So you changed it back when? And in the end of the year?
I don't know the exact date, Dr. Arifin, but I believe it is, as Dr. Manopo indicated, I believe it is in October, late October.
Okay.
So I'm not exactly sure of that date, but it's roughly 6 months, on daylight saving time, 6 months not on savings time.
Okay. Good evening, Dr. Johnny. Good evening, Prof. Hendy.
Good evening, everybody.
Yeah. Good evening, everybody, especially for Max in America, in the United States.
Thank
Nice
you.
to meet
Yes.
you again.
It's nice to see you again, Dr. Jamaja.
Yes, thank you.
Dr. Johnny, are you still busy with PABI or you have a break?
Yeah, little bit with PABI. Now on, we have problems, slight problem with our college because our college not really like we want. They go fast. Maybe
too
Dr.
fast.
Frans can tell us. But some friends complaining about why the college go fast without bring us with them. Yeah.
Yeah, it's in a big organizations. A lot of people. There are different paces in moving. Some are very fast. Some are more conservative. So yes, it's it's always a problem, but we will manage it. I think Dr. Johnny is very experienced in this types of problem.
Yes.
Dr. Yopie Habibie, are you on the line? Good afternoon, Professor Tsoulfas. How are you doing?
Good afternoon. How are you doing, Peter?
Yeah, I'm good. I hope you are healthy and well.
Yeah, for the time being, continuing to be so. Things are getting a little bit more back, more active here with the COVID virus, but we're staying okay.
What is the condition of the virus in your country, Prof. Tsoulfas?
It's increasing again.
Oh, okay.
We're started with the vaccinations, but it's actually increasing. We've had the hospitals are getting a little bit more
Crowded.
ICU beds fewer and fewer available. Where things are moving backwards a little bit.
So you have a second peak, or going to the second peak?
Well, this is, I guess, the third wave.
Oh, the third wave.
We've already had two. We had the
Okay.
initial one back in March, April. We had another one just after the summer. The first one we did very well because everybody was afraid after what we saw happen to Italy, and I see Giuseppe, my friend over there, and the second one.
Hi.
Hi, Giuseppe.
Hi, George.
Second time things, we were a little bit putting things together, but things ended up calming down. The vaccination started. But it looks like it's getting active again.
Do you have a lot of vaccination already? How many percentage of the population are vaccinated?
Small. It's about 10%.
10%. Oh,
Yeah.
but it's quite large compared to Indonesia. I think because we have a lot more people, so the percentage is quite small currently.
Right. It's we'll see. Okay, so.
Good evening, Professor Nigri. How are you doing?
Good evening. Good. How are you?
I'm good, thank you. Thank you very much for your contribution for speaking in this event.
Thank you for inviting me. I'm very happy to be here.
Yeah. Thanks. We will get started in 2 minutes. Dr. Yopie Habibie, are you on the line? Professor Paul Tahalele, are you on the line already? Good morning, good afternoon, and good evening, everyone, and welcome to the 13th chapter Surgical Forum of the International College of Surgeons Indonesia section. My name is Peter Johannes Manopo. I'm a general surgeon as the coordinator of the Surgical Forum, and I will be your moderator in this session. First of all, on behalf of the International College of Surgeons Indonesia section, I would like to express my gratitude to all participants, particularly the speakers, our guest speakers from the Royal College of Surgeons of England, Professor Giuseppe Nigri, and the other speaker from the Indonesia section, Dr. Yopie Habibie, and also Dr. Hari Nugroho, the OBGYN surgeon from the ICS-Indonesia section. Also to the World President of the ICS, Professor Georgios Tsoulfas from Greece, and the World Executive Officer of the International College of Surgeons, Mr. Max Downham from the US, and the Indonesian office bearers, Professor Paul Tahleli as the section president, Professor Hendy Hendarto, the vice president of ICS Indonesia section, Dr. Johnny Dharmajaya, the vice president of the ICS Indonesia section, Dr. Frans Arifin, the secretary of the Indonesian section. Now we come to the opening speech, and the first opportunity I would like to invite Professor Paul Tahleli, the section president, to deliver the opening speech. Professor Paul Tahleli, the floor is yours. We will skip, maybe later on he will join us. I would like to invite Professor Hendy Hendarto, the Vice President of the Indonesian section, to deliver the scientific notes. Professor Hendy Hendarto, the floor is yours.
Thank you, Dr. Manopo. Good evening, everybody. Welcome and thank you for joining International Virtual Surgical Forum, Chapter 13. I would like to express my deepest gratitude and appreciation to Professor Paul Tahleli, Professor Giuseppe Nigri, and Professor Georgios Tsoulfas, Mr. Downham, Dr. Johnny Dharmajaya, and all the speakers, and also Dr. Frans, Arifin, Dr. Peter, and all webinar participants. The webinar topic today is surgery and patient safety. From scientific note, WHO informed about why safe surgery is important. Unsafe surgical care can cause substantial harm. First, the reported crude mortality rate after major surgery is 0.5 to 5%. Second, the nearly half of adverse events in hospitalized patients are related to surgical care. And last, at least half of the cases in which surgical lead to harm are considered preventable. That's all I think about scientific note. I hope we all stay healthy and stay safe. And finally, thank you for the speaker for sharing your experience. Thank you very much for your attention.
Thank you very much, Professor Hendy Hendarto, for your speech. For the next opportunity, I would like to invite the president of the International College of Surgeons, Professor Georgios Tsoulfas from Greece. Professor Georgios Tsoulfas, the floor is yours.
Thank you very much, Dr. Manopo, my good friend Peter. I really want to thank you, first of all, for the honor and the privilege of being part of this event. And there's a long list of things that I really want to congratulate you about. And first and foremost, for creating something that is very well attended and provides a vital resource to surgeons of all ages and of all levels in this difficult time that we live in. And because we don't have the opportunity to get together in person, these are excellent opportunities. I really also want to congratulate you for now having a tradition. This is not a single event, it's something that's happening with a very significant rate, and that's very important. And this is becoming bigger and bigger. And I don't mean just within Indonesia. I think the attendance and the international attendance that you're having essentially means that this has all the right ingredients to go to a different level. And the other thing that I really want to congratulate you is for the topics that you're choosing. These are the topics that are most valuable to every surgeon around the world, no matter where they are. These are topics that apply to all of us, no matter what the specialty, and because they have to do with patient safety. And these are evolving topics. These are not there. We don't have all the answers. We're developing them. And I think it's really great to have such opportunity to talk about them. And the last thing, because time is precious, is that you really have an excellent list of speakers, both from within Indonesia as well as internationally. I see my good friend, Professor Nigri from Italy, who's a world-renowned expert on things. And so really congratulations. You're really doing a big honor to the ICS and to Indonesian surgery with what you've created. Thank you again for allowing me to participate.
Thank you, Professor Georgios Tsoulfas, for your speech. And now I would like to invite Professor Giuseppe Nigri from the Royal College of Surgeons of England to deliver your introductory speech. Professor Nigri, the floor is yours.
Thank you. I'm glad to be here today. I'm glad to represent the Royal College of Surgeons, but I'm also glad to represent the International College of Surgeons. Thank you, George, for your notes. And I have to agree with what George Tsoulfas just said. I mean, I congratulate you because of the participation of the people to this event that was huge. I saw last time during the last meeting was amazing. And also because of the topic, because today we will talk about safety in surgery. And this is probably one of the most important topics in surgery that has to be considered each time that we go to the OR. So thank you so much for inviting me today. I'm very honored.
Thank you, Professor Nigri, for your introductory speech. And now I would like to invite Mr. Max Downham, the CEO of the ICS Global from US. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo, Professor Nigri, Dr. Habibie, and Dr. Nugroho, as well as the leaders of the Indonesian section. I fully agree with Professor Georgios Tsoulfas, our distinguished world president from Thessaloniki, Greece, in terms of thanking you and expressing admiration for the Indonesian section in terms of setting this exemplary example of doing virtual learning. I think it is superb, and it's a privilege and honor for me to be part of it. I thought I might take, Dr. Manopo, just a quick minute to talk a bit about Dr. Max Thorek. As I think most of you are aware, Dr. Thorek founded the college in 1935. He founded our journal, International Surgery, in 1938, was the first editor-in-chief. And so he had a few philosophical points, one or two of which I will touch on, which Professor Tsoulfas, I think, also did. One is that the purpose of the college is to bring leaders of the world in surgery and healthcare together to establish better understanding, goodwill, and I think peace. Another one is that this is in a book that Dr. Thorek published in 1940 or 1941. Everyone in the college should be one and the same. Teacher and student. And it seems to me, as a layperson, I'm neither physician or surgeon. As a layperson, it seems to me that what you're doing, Dr. Manopo, and the leaders of the Indonesian section are only to be commended. And I believe the philosophy of Dr. Thorek is as applicable now as it was in 1935, and perhaps it's even more applicable. In the International College of Surgeons, as Professor Tsoulfas and the leadership of the college have expressed in recent years, our focus is on humanitarian surgery. And certainly our relationship with the World Health Organization, an official relationship as a non-governmental organization, we have a key role there as expressed by the WHO in terms of developing sustainability and humanitarian surgery at the local level, and certainly in terms of advocating the need for humanitarian surgery. Lastly, in preparing for this, I note that Dr. Thorek published a book in 1932 entitled Surgical Errors and Safeguards. And I'm not certain as a layperson how much of that relates to your topics this evening in Indonesia, but it is relevant. And so I thank you again, Dr. Manopo, for the opportunity and the privilege to address this group. Thank you.
Thank you, Max, for your speech. And now I would like to invite Professor Paul Tahlili, the section president. Professor Paul Tahlili, the floor is yours. Okay, we will skip maybe later on. I would like to invite Dr. Frans Arifin, the section secretary, to deliver the section issues. Dr. Frans Arifin, the floor is yours.
Thank you, Dr. Manopo. May I share the screen?
Yes, please.
Okay. So I'd like to inform all of the members of the Indonesian section about two topics. First, following up what Max has already mentioned, that we have a special relationship with the WHO. So we have monitored and followed up more or less the program of the WHO. This is one of the topic that was raised this year, which is ageism. And ageism related to us because we will have between 2015 to 2050 more than double the number of the world population which reach over 60 years old. So it will be up to 22%. And by the year 2020, this year, the last year, the number of the people aged 60 and older will outnumber the children younger than 5 years old. So as we all well know that a lot of health programs in Indonesia are focused for the under 5 years old, but now the number of the people who are aged over 60 is increasing more than the number of the children under 5 years old. This will be a challenge for us, the surgeons, and related to our topics today, it is that the number of the populations that will need surgery and surgical services who are over 60 years old will be will increase. So I would like to invite all of the members of the College of the Surgeons in Indonesia to try to understand the topics of the ageism and aging related to surgical treatment and surgical services. So in the future, we will be able to serve better the increasing number of the aging population. That's the first one that I'd like to announce. The second one is that this year, on November 17th to the 19th, we will have the 42nd ICS Biennial Congress, which will be held in Thailand. So maybe in the few months we will distribute the invitations, and we'd like to invite all of the members of the ICS Indonesian section to attend and meet together in this meeting. Hopefully the travel limitations will be raised on that date. I don't know. We are now have less number of the COVID-19 cases, but I don't know in the end of the year. Hopefully, we can travel at that time. There are two meetings before the ICS global meeting. The one is in the States in June, and the other one is in Japan, also in June. So these are the announcement, and maybe some of the surgeons, the members, are interested in joining these surgical meetings on different ICS national sections. I think that is all for the business issues. I return the time to Dr. Manopo. Thank you for the opportunity.
Thank you, Dr. Frans Arifin, for your issues delivery. So now I would like for the first session of the scientific session will be Dr. Yopie Afriandi Habibie. He is a thoracic surgeon and he will speak on patient safety in thoracic surgery. Dr. Yopie Habibie, the floor is yours.
Thank you, Dr. Manopo. Thank you very much for the ICS-Indonesian section who already invited me to share a little bit about my experience in thoracic surgery. I would like to say greetings also to Professor Nigri. How are you? Professor Nigri,
Thanks, I'm
Mr.
fine.
Max. Hi. And also Professor Tsoulfas. Dr. Doni, how are you, Dr. Doni? And all the ICS Indonesian section members. Now I would like to share my screen.
Thank you. Yeah.
Has everyone seen my screen clearly?
Yeah,
Yes.
clear.
Yeah, thank you very much. So I would like to start my presentation. Now I will ask, the committee asked me to talk about the patient safety in cardiothoracic surgery. I will share a little bit about these topics. So I have no disclosure in this presentation. So as an introduction, safety is everybody's business issue. So if you are talking about surgery, so safety should be the first thing that we should keep in mind to when we're doing some surgery to our patient. And according to the Hippocratic Oath from the 5th century, please do no further harm to anyone, including to our patients, especially if the patients, our relatives, our family. Please do the best surgery, the best service that you can perform to our patient. And safer surgery is also a reduction of affordable harm to all surgical patients. So this is should be delivered to all our surgical colleagues, to all our residents, that please do not do any further harm to any other patient. If we want our family, if they are in the patient side, should be treated very well. And surgery is a part of medical specialty that use operative manual, and the patient should be treated very well. And also in surgery, the surgical team consists of the surgeons itself, the surgeon's assistant, it's maybe the residents or a trainee, and the anesthetist, scrub nurse, and circulating nurse. So all these team members who are involved in operating theater should know that all their procedures should be safe when they would like to perform any kind of procedure in their daily activity schedule. So this should be kept in mind. And the surgical periods is that we call the time or duration of patient admitted to the hospital and discharged after the completion of surgery. So during these surgical periods, every patient should be kept in priority for their safety. Yeah, the safety itself should be performed from the team, and also from the patient, and also from all the team members that involved in the surgery. Surgical safety has broadly included in different phases. First is pre-operative, when we would like to know what is the diagnosis, what should we investigate for the patient, such as like the imaging from chest X-ray or CT or MRI or ultrasound or from the physical examination. We should make a clear diagnosis before we schedule a patient to surgery. Intraoperative means when we're doing the surgery, we have to do the surgical safety checklist. Like already delivered by the WHO, that surgical safety checklist is a mandatory to prevent any adverse event during the intraoperatively. So we have to do sign in, sign out, and we have to check all the surgical safety checklist check. So in the postoperatively, the patient will goes to the ward or will goes to the high care unit or will goes to the intensive care unit. So wherever the patient goes after the surgery, we have to look after the patient as well. We have to collaborate with our colleague in the ward, especially in the intensive care. We have to collaborate with our intensivists how to manage the patient very well, so the patient will get the best treatment for their cases. So how safe is the surgery? An article from the Guardian newspaper in UK from March 2013 claimed that the 5 worst medical nightmares in patients face 3 related to surgery. First is the wrong side of surgery. We have to make a landmark before we schedule a patient in surgery, before we deliver the patient from the ward to the OR. We have to make a landmark. Where is the side of surgery? Is it the right side or is it on the left side? Is it on the upper part or is it on the lower part? So we should make a landmark. So intraoperatively, we don't make any wrong incision, wrong patient surgery. We have to identify the patient prior surgery, prior the patient move forward from the ward to the OT. Is it the name of the patient was correct? Is it the date of birth of the patient was correct? Is it the medical record of the patient was correct? So we will avoid the wrong patient of surgery, because it's often occur that we did the procedure to the wrong patient, even though the name was the same, the name of the patient was the same. So we have to identify between the date of birth or the medical record number, the ID of the patient, and retain the instruments and the swab. This is also we have to move forward. The rate of harm in surgical patient is unknown, but probably occur in about 10% of surgical patient. Too much of this one will be minor. So now we're going to talk about the surgical error. Surgery is one of the most complex health intervention to deliver. More than 100 million people worldwide require surgical treatment every year for a different reason. So surgery is like a daily business for a surgeon. We have to do any kind of procedure in the OR, but we have to keep in mind we have to go priority for the patient safety. So the great professor from surgery, Sir Alfred, and other describe surgical error in different categories that committed to by the surgeons during the care of the patient. What is the Sir Alfred Kusheri mentioned? First, the diagnosis and the management error. We have to avoid the wrong diagnosis. We have to avoid that we manage the patient not very well. We have to avoid this so the patient will be safe. The resuscitation error. What we are going to talk about the resuscitation. When the patient came with trauma, with thoracic trauma, what should we do to make the patient still alive with the life-threatening condition? We have how to manage the good airway management, how to manage the breathing, how to manage the circulation. If we manage the patient wrong, so all the damage will goes to the patient, not to the doctors, not to the surgeon. So we have to do a better resuscitation by gaining our knowledge. We do a proper training when we're still in residency or in the training period. So prophylactic errors, prescription and parenteral administration errors. We have to communicate very well with our nursing. When we prescribe a medicine, when we order an IV injection, we have to make it clear. Don't inject any IV wrong. Don't inject any medication not in the proper time as it mentioned on the prescription. So we have to check this earlier before we do the medication. situation awareness, identification, and teamwork errors. This is also, we have to build a good communication between all the teams member. Technical and operative error. We can avoid it with gaining our skills during the period of residency and the training. We have to take a workshop, advanced workshop, to increase our skill to avoid the patient to avoid the patient problem during the surgery. Now we're going to talk about the situation awareness, identification, and teamwork errors. Wrong patient in the operating theater is often occur. Surgery performed in the wrong side, as I mentioned before. Wrong procedure. We want to do, especially like decortication in pleural tuberculosis, but we're not doing very well. So it's not good. Failure to communicate change in the patient's condition. If we are trying to do some procedure, but intraoperatively we face with another difficulty, we have to talk to the patient relatives. Disagreement about the proceedings and retain instrument or swabs. Now, from the Joint Commission, they have the universal protocol to preventing wrong side, wrong procedure, and wrong person surgery. We have to speak up as a patient, as a relative. They have to speak up to their doctors, and also we as a doctor have to hear about what they are talking about their complaint. We have to take good care about what is their complaint. They speak up, we have to hear, and after we hear, we will do our best treatment to the patient. And also, why wrong side of surgery? Wrong side of surgery is often occur in the patient, and we have to reduce the risk of wrong side of surgery. So nowadays, all the international hospital, all the top national hospital already accredited by GCI. So the GCI is make a very strong regulation to maintain the patient safety, especially the patient center safety, but not only the surgeon, but the patient safety. How we are going to reduce the process errors, reducing or wrong or safety surgery? Now, this is the process. We have to, from the booking error, from the verification error, from the distraction or rush hour when we're doing surgery, we have to reduce all these errors. Inconsistency of the site marking, no safety culture during all the team, from the ward, from the OT and the post-operative care. We have to reduce all those things. So if we can reduce all those things, we can prevent the wrong side of surgery. We can increase our patient safety, when we can increase our quality of treatment to all our patients during treatment in the hospital. How can surgery be made safer? Right surgeon, right place, right time. Right surgeon means the surgeon should be adequate training and experience. Training surgeon require updating in the current technique and training a new one. If we have a case like in my specialty, if we have a case like a thoracic trauma or a cardiac trauma, it should be the right surgeon to perform the procedure. Otherwise, the result will not be that good. So the outcome of the result should be is the highest priority. If one surgeon cannot perform the surgery very well, he should consult to his senior surgeon. So his senior surgeon will get involved to perform the surgery, so the patient will get the best outcome. Right time applicable for emergency surgery. If we don't have any attending surgeon at that time, if we have an emergency case and I don't have any good experience on doing that procedure, we can consult to our senior surgeon how to do this procedure, how to save this patient. I have one experience. My junior surgeon, he had a patient with a stab wound on the chest from the left to the right chest, and then he consulted to me that how I can manage this patient. After I'm giving him the strategy, the tips and tips how to manage the patient, and then he can do the procedure very well, and the patient was survived, and then the outcome was very, very good. Now we are going to talk about what is the risk, assessing the mitigation risk in the cardiothoracic surgery. This is from the Annals of Thoracic Surgery from 2016. So this is one statement from William Bruce Cameron: not everything can be counted, and not everything that can be counted counts. So the definition of risk included the possibility or danger of injury or loss, So every our procedure can make a possibility of danger. A person or thing that created a hazard and the chance of financial loss. If the patient not get very well treatment, so all the costs will be higher, all the budget will be increased, and the financial losses will be more huge. Now in Indonesia, we have a national coverage for every medication. But if the patient not goes to the government hospital, the patient will goes to the private hospital. So it will increase the financial loss of the patient if we're not doing a very good work for surgery. And how about the decision-making evidence and practice? Routine use of evidence-based medicine and evidence-based practice. Evidence-based medicine means that the consistence, the explicit, the judicial of the current best evidence is making the decision about the care of individual patient. And the randomized control trial is the gold standard in evaluating every therapy in evidence-based medicine. So if we are doing treatment to all the patients, we should use the EBM. EBM is the highest rank of the evidence that result from the research. If we do the RCT, if we do the systematic review, so we have to look after what is the evidence base of this kind of procedure. What is the best evidence for this procedure? We have to follow that, and we have to adapt that also in our situation in Indonesia. For example, in Aceh, the local resources will not be the same like in Jakarta, in Surabaya, or maybe in other part of Indonesia. In Indonesia will be not the same maybe in US or in Europe or in Australia. So we have to adapt that what the results that we have. The EBP include the information regarding the diagnosis, prognosis, therapeutic, management strategies, and outcome through the quantified measurement and analytic. This is the 6 key roles when we are faced with a patient with a cardiac arrest. So we have to know where is the internal defibrillator, where is the device if you have to do the DC shock, where is the ventilator to manage the airway and the breathing, where is the team leader, where is the drug and the sirens, where is the ICU coordinator. All those things should be managed very well intraoperatively. So the surgeon will be the key leader when the damage or when there is a dangerous happen during the surgery. The key leader, the surgeon should be on the he should know what should I do if I have a patient like this. If when I'm doing the surgery, when I'm doing a cardiac surgery, a K-base surgery, the mitral valve surgery, if I have a patient suddenly cardiac arrest, what should I do? I have to know. I have to know what should I do, and I have to communicate with my anesthesiologist. We have to make a good communication so the patient will be survived. And I have also an experience. A patient with coronary artery disease with low ejection fraction and will perform urgent CIBG. When the anesthesiologist did the pre-medication, the sedation, the patient will go cardiac arrest. And then I have to perform IABP. I have to open the chest immediately, and then I have to go on bypass. What is the key point of this scenario? Just to save the patient. If I don't have a good proper training, I cannot save the patient when the patient is during anesthesia. So we have to build a good collaboration with our colleague, especially anesthesiologists, intraoperatively. And now is the EX guideline, the use of patient safety checklist. From the EX, create a version of the checklist that might be more appropriate and specific to thoracic surgery, including checks on preparation for excessive bleeding after surgery, after CIBG, after mitral valve repair, mitral valve surgery, aortic surgery. We have to check whether the patient will have the chance of post-operative bleeding, perfusion arrangement, and ICU preparation, for example. Now, this is one of the cardiac surgical safety checklists. We have to go sign in, time out, and sign out. All these checklists should be checked by the the authority, the scrub nurse or the circular nurse who are responsibility to check all this checklist. So we have to make the identity confirm, the site marking is okay, the consent from the correct and sign already from the family relative should be okay. All those things should be checked. If there is one box that not checked already, don't go proceed to surgery. Don't insert the patient to the operating room if we're not doing the sign in completely. The time out as well like that. So before the surgeon start the incision, we should identify who is the surgeon, who is the assistant, who is the scrub nurse, what is their responsibility. We have to speak up to the responsibility guy. And the sign out after after the surgery was finished, we have to do the sign out and then sign all this surgical safety checklist before the patient sent back to the ward or sent to the high care unit or into the ICU. This is one of the example of the cardiac surgical safety checklist. Also the sign in, time out, and sign out. This is for a congenital heart surgery safety checklist. Also sign in, time out, and sign out, but there is some different, some unique surgical safety checklist between all those procedures. And this is one of the guidelines from India that they are doing during this COVID-19, and they need to establish the guideline for practice of the cardiothoracic surgery, which is safe for both the patient and the healthcare team present and as their priority. So if they have a patient for surgery, they will propose preoperative testing protocol. If the patient have suspected or probable case, they will they will schedule patient as an elective. If the patient elective or emergency, if the patient have a confirmed case as well, elective or emergency, they have this protocol. This protocol should be followed by all the team member, including the surgeon, the anesthesiologist, the scrub nurse, the ICU. This came from the top management of their hospital. So this will make the team member be safe during this COVID-19 period. This is one of the article from the Journal of Thoracic Disease from 2015, the Patient Safety in Thoracic Surgery, and the European Society Thoracic Surgeon checklist. There is an adverse event can be defined as any injury due to the medical care. So adverse event will go to the patient, not to the team member, not to the surgeon, not to the anesthesiologist. The adverse event will go to the patient. So we have to make it clear from the diagnosis, intraoperative procedure, and the postoperative care. And there is represent a major source of morbidity and mortality. This is also the example for the ICS about the surgical safety checklist before induction of anesthesia, the sign in, time out, and also the sign out. There is a little bit specification from the ICS and the EX guideline. The EX guideline also mentioned about the cardiac surgery checklist. The SCS only the thoracic surgery checklist. But overall, we have to do the sign in, time out, and sign out. This is also mentioned in the WHO surgical safety checklist. This is one of the patient safety science in cardiothoracic surgery as an overview. We make two implicit individual and organizational promises when the patient entrusts themselves to our care. First, to do everything possible to provide excellent care. This is the key point, excellent care, the best treatment that you can perform to all your patients. And second, please do not do any further harm. In some instances, patients do not get the care that is expected and inadvertently harm. So this is one of the mental workload in the operating theater. So preoperatively, the surgeon still not have stress, but intraoperatively the stress will go up, and postoperatively the stress will goes down. So intraoperatively the surgeons and the anesthesiologists will their stress, their mental workload will increase. So during that situation, we have to take control ourselves to do the best treatment, the best procedure for the patient, even though there is some complications, some difficulties that we face during the procedure. So this is the attributes for safety focused surgical teams: training together as a team, consistent leadership from the surgeons and also from the anesthesiologists, Physiological safety and the ability for teams member to voice concern. We have to talk each other's, clearly define the boundaries of action and behaviors. We should behavior very well during among all the team member. Role clarity among all the team member, team structure, team briefing, debriefing after surgery, mechanism of conflict resolution if we have a conflict during surgery, and share accountability. All this can we do, we perform to make our procedure, to make our treatment will be the excellent care.
You have 2 minutes left.
Yeah, thank you, Dr. Manopo. And the other thing is the patient safety, disclosure of medical errors and risk mitigation. To err is human. Building a safer health system, this is one should be keep in our mind. This is one of the steps that we can do the mitigation if we have an adverse event in the hospital. And the ethics of managing risks from the American College of Physicians. Physicians should disclose to patient information about procedural or judgments error made during the care, as long as the information is material to the patient's well-being. Error do not necessarily imply negligent or unethical behavior, but failure to disclose them away. As a summary, keeping patients safe from unintentional harm will require a new approach involving enhanced communication, practice, workflow redesign, and leadership style. Achieving a climate of safety and developing system-based approach to safety will require commitment from all the stakeholders of team members. The cardiothoracic surgeon of the future will be not only an expert technical surgeon, but a collaborative leader with strong communication skills and deep understanding of the complexity and interrelatedness of all parts of the system. This is one of the picture. The take-home message: teamwork is a successfully will deliver the best treatment to all the patients. Thank you very much. Thank you, Dr. Peter.
Thank you very much, Dr. Yopie Habibie, for your informative presentation. And I would like to invite Professor Giuseppe Nigri, who will talk on patient safety on GI surgery. Professor Nigri, the floor is yours.
Okay, can you see my presentation?
Yes, clearly.
Okay, perfect. So thank you, Dr. Manopo, for inviting me here today. And I want also to congratulate Dr. Habibie for his talk, because it was very comprehensive and he really summarized all the aspects of surgical safety, which is not valid just for thoracic surgery, but for surgery in general. So thank you for that. Well, I have no disclosure, and I was invited, I was asked to speak about safe anastomosis in colorectal surgery, mostly something directed to trainees. And what I want to talk about and to focus on, it's mostly on the complication of colorectal anastomosis and how to avoid them. So minimal invasive surgery for colorectal cancer is considered a safe procedure due to evolution of pre-op preparation, antibiotic prophylaxis, surgical technique, surgical devices, and also post-operative management. But it provides favorable results with less blood loss, lower conversion and complication rates, satisfactory lymph nodes are vested, but operation time is relatively longer compared to open surgery, as we know, robotic and laparoscopic. However, bowel anastomosis still remain a major concern for outcomes in colorectal surgery. And this is mostly due to the status of the patient, of course, and the comorbidity that the patient can have, surgical technique, selected devices, condition of the bowel, and all these are key factors for a successful anastomosis. Now, the complications of colorectal anastomosis are maybe can be summarized in 4 points: bleeding, leakage and dehiscence, stenosis, and fistula. But they all negatively impact on patient outcomes. And most of the bleeding, now we talk about the first complication, the bleeding. Most of the bleeding from an anastomosis is self-limited, and it will stop spontaneously and does not need blood transfusions or interventions. However, bleeding can occasionally result in dynamic instability that requires blood transfusion and endoscopic or angiographic or even surgical intervention to cease. And the reported rate of bleeding is about 4.2%, and there is no significant difference between stapled and soon anastomosis. Now, how to avoid bleeding? What are the major points, major safety points to avoid bleeding? We need to avoid including the mesentery in the staple line, first of all, if we are doing a mechanical anastomosis. And also we have to adjust the high thickness of the stapler, because otherwise, if, for example, the staples are too low in eye, they can reduce the vascularization of the anastomosis. But if they are too high, they can let the anastomosis bleed. So the other dreaded complications are leakage and dehiscence. And we know that the leak rates of colorectal surgery depend on the level of the anastomosis, which below the peritoneal reflection are greater than above the peritoneal reflection. It means 6.6% versus 1.5%. What about mechanical preparation, bowel mechanical preparation? Does it influence at all the anastomosis? Well, it is still matter of debate. There are no current consistent data that can correlate with mechanical bowel preparation with anastomotic leakage and dehiscence. Instead, circulation is extremely important. It's crucial, I would say it's crucial, because it relies on the blood flow, the marginal artery proximally on the descending colon, and distally after TME, total mesorectal excision, its blood flow relies on the inferior hemodoral vessels only. So other things that we have to consider are tension, because tension on a colorectal anastomosis not only compromises circulation to the anastomosis, worsening the critical situation of blood supply that we mentioned above, but it also creates a chilling force. Obesity and male gender also.
Excuse me, for all participants, please mute your microphone except the speaker. Mr. Bimo, please mute all the participants' microphone because it is disturbing.
Okay, so I was saying that obesity and male gender, which means narrow pelvis, increase the difficulty and complexity of rectal resection with significant high rates of leakage. So what are now the major safety points to avoid leakage and dehiscence in case of colorectal anastomosis? We need to optimize the perfusion of the resection margins. And we can do this today with fluorescence imaging using indocyanine green, which is a novel technology to visualize the perfusion of the transection line. So the surgeon can decide where is the point with optimal blood perfusion for transection. And Jafari and colleagues reported that the rate of anastomotic leakage was significantly lower in the IG fluorescence imaging group, 6%, than in the control group, which was instead 18%. Now, tension, how to avoid tension? Tension should be prevented with adequate mobilization of the colon. The staple height, we said that before, we should consider the staple height to prevent failure in microcirculation at the anastomosis site. This is actually the opposite of what we saw for the bleeding. Staple line reinforcement, it remained controversial and inconclusive. There are no data, no current powerful data that can demonstrate the efficacy. There are no current data that support the use of fibrin glue. Instead, many surgeons use an intra-op dye test which examines the watertight and airtight of a colorectal anastomosis. And this test helps surgeons to make decision to reinforce the anastomosis with additional suture or to create, for example, the functioning stoma. To drain or not to drain the extraperitoneal anastomosis after rectal cancer surgery? Well, a large observational prospective study of more than 900 patients demonstrated that anastomotic leakage increased significantly with drains in patients receiving low anterior resection for rectal cancer. While another study, another randomized clinical trial, found that a pelvic drain in the in case of an extraperitoneal anastomosis after rectal cancer surgery had no significant benefit in clinical outcomes compared to the other group. Also, we have to consider that chemoradiation and TME, total mesorectal excision, for middle and lower third rectal cancer can result in a higher rate of sphincter preservation, but also a higher rate of anastomotic leakage and pelvic sepsis. And in this case, a pelvic drain not only eliminates accumulation of fluid and contamination, but also detects anastomotic leakage. What about diverting, protective, and the functioning stomas? We know that they do not decrease the rate of anastomotic leakage. However, stomas minimize the severity and complication of leakage and decrease the rate of reoperation. In any situation where possibility of anastomotic leakage is encountered, a loop colostomy or ileostomy may be beneficial. Another complication of colorectal anastomosis is stenosis. And the stenosis may be the complication of anastomotic ischemia, leakage, dehiscence, and can be caused by also inflammation, radiation, a recurrence of malignancy, and the stapling technique. Stenosis occur more likely with stapled colorectal anastomosis versus and soon, which is about 6 versus 2%. And the incidence of stenosis of colorectal anastomosis is greater in male than in female gender due to surgical technical difficulties in narrow space, narrow pelvic space, as we saw that before. And sometimes the diameter of the proximal colon is too small to do an end-to-end colorectal anastomosis, and the side-to-end colorectal anastomosis is an ideal option to prevent anastomotic stenosis. And last complication of colorectal anastomosis is the fistula. And different type of fistula can develop between the anastomosis and the skin, the genitourinary tract, the presacral space, the vagina, and the causes are also in this case anastomotic ischemia, leakage, and dehiscence. So we need first to be sure about vascularization, about blood flow to the stumps, colon and rectal stumps. That's the crucial part to assure, to avoid leakage, dehiscence, fistula, stenosis. That's the most important part. Also, it can be an early complication, fistula, of inadvertent inclusion of the posterior vaginal wall into the stapling device. And pre-op neoadjuvant radiotherapy is another risk factor for fistula. So in conclusion, we will check all the points that we have to, let's say, to include in our list to avoid complication of colorectal anastomosis. Bleeding. So we said avoid including the mesentery in the staple line and always consider the staple high. Leakage and dehiscence. Optimize the perfusion of the resection margin, and let's use the IG fluorescent test in laparoscopic surgery, of course, or robotic surgery. Tension should be prevented with adequate mobilization of colon, so bring down the left flexure. Intra-op dye test can help the surgeon to make a decision about, for example, stoma, the construction of a stoma. It's better to drain in case the patient had chemoradiotherapy and TME. And stomas minimize the severity of complication of leakage, but do not decrease the rate of anastomotic leakage. Stenosis, we said neoadjuvant radiation therapy can cause stenosis, so we have to take that in mind. We need to avoid anastomotic ischemia and leakage and dehiscence. Stapling technique can make the difference in this case. And fistula also in this case, neoadjuvant radiation therapy can be the cause. So avoid anastomotic ischemia, leakage, dehiscence, avoid inadvertent inclusion of the posterior vaginal wall into the stapling device. Thank you.
Thank you very much, Professor Nigri, for your nice presentation. I would like to announce that please all participants mute their microphone except while speaking. So for the next opportunity, I would like to invite Dr. Hari Nugroho. He is an OBGYN surgeon, and he will talk on the patient safety in OBGYN surgery. Dr. Hari Nugroho, the floor is yours.
Thank you, Dr. Manopo, and thank you for all the organizing committee that inviting me here. I'm so happy that I could share about the patient safety in the OBGYN operation. So I work in the academic medical hospital in Sutomo Hospital, Surabaya, Indonesia, and I'm a gynae oncologist and also a minimal invasive surgeon. So I would like to talk more about that later. So first of all, I have no financial disclosure or conflict of interest in this presentation. So why we have this kind of talk is one thing, because making errors is part of normal human behavior. So as a human, we always create errors. So this is our daily activity. We are always making errors every day. We always forget our keys, our wallets, our coins, our phone, our sunglasses, maybe our wife, I don't know. And even Google's have a button called forgot password, because we all are human. But what happened in the very high risk profession like a pilot, can they forget to land? No, they cannot, because in pilot error, you will get a lot of damage, a lot of cost. And also, we are, as a surgeon, we cannot forget to cut, forget to stitch, forget to everything, because what our error gonna have a lot of do. We always see in the news every day, like doctor amputates wrong leg and etc. because of doctor errors. So in other hand, we are human, which always create error every day. But in other hand, we as a doctor, we are pushed not to be make error. So we need to be a superhuman. How to do that? We have a lot of tools to do that, including the JCI. Goal number 4 is to ensure safe surgery. So what is patient safety? From the data from the JCI from 1995, the wrong side surgery is the most frequent reason of error. And in the OBGYN world, thank God, only tubal ligation without consent. So we don't really have a lot of wrong side surgery. What is the terminology of wrong side surgery? Maybe Dr. Yopie already stated about this one, but maybe I gave you more about. It's a wrong patient, wrong body parts, wrong side of the body, and also the wrong level of the correctly identified anatomic site. And in the latest publication in 2020, thank God, the gynecology department is very, very low. Only 1 in 2,671 cases. And the most surgeon that create error is the ophthalmology in 1 in 87 cases. That's very, very big. And in the gynecology, this one cases is only performing the tubal ligation without consent. So it's not really catastrophic human error, but still. What can make you high risk for wrong side surgery when you have a multiple surgeon involved in the case? In my case, usually I do operation with the GI surgeon, with the vascular surgeons, and urology surgeon to do pelvic accentration and things like that. So things like that will tend to have a wrong side surgery, and also multiple procedures and unusual time pressures, like your wife keep calling, you have dinner at 7, go home right now, and you will tend to have a very wrong side surgery. And unusual physical characteristic of the patient, in morbid obesity and physical deformity, you will have a very high risk for the wrong side surgery. And how to improve that? In my hospital, we are GCI accredited, so we are using the 3-step from the pre-procedure verification process, from the document, and then we have to identify the label and everything. If it's not correctly identified, then we are not continuing. And then the second one is the marking of the operative site. In my world, in gynecology, we don't really have that because we are doing in one place, and performing a timeout before the procedure. So this 3-step will save less human error. And also the other one is from the WHO, the surgical safety checklist. Thank God, again, in the OBGYN department, it's not like in the vascular surgeon from Dr. Yopie. They have a lot of checklists. We only have a simple checklist like this. And that's why, maybe because we are having the organ in the center. And then more and more, we are now involving the patient to create less human doctor's error. We are checking the patient before the surgery, the patient knowing the doctors and stating the name and stating the diagnosis, and also stating the procedure that's going to take place. If the patient say yes, then we continue. And the patient involvement is becoming more and more keys to increasing the safety. And this one, we have that a lot, especially in the gyne-oncology. We always introduce new procedure of surgery. It's a very, very good things, actually. A new procedure mostly will create a better outcome. But this is represent a source for potential surgical error, because a new surgical technique, mostly the new surgeon is not really really good at it. Then the hospital should be asked for the supervisor or a senior to supervise first before you can continue with that procedure. And if there is no surgeon that are good enough in that hospital, then you should not let that surgeon do alone. You should ask for another surgeon from another hospital to proctor or to supervise first. And then the surgeon that doing that should be documented skills and experience in that surgical area. And then this is the most important thing in my world as a gyne oncologist and minimal invasive surgeon. We have a lot of equipment almost every year. So it's like in the aviation world. In the old days, we have a pilot with only 5 coach, manual coach like this, right? But more and more, they got like very huge knob like this. Maybe I'm the one that trained for this kind of thing. It's easy for me to understand. I know where the places is, but it's sometimes it really overwhelms me to train another scrub nurse and instrument guy and everything. So it is a very high source for error. Especially the new one, they only put one glass and then you can check everything on it. It's not so easy. That kind of thing also happened in our world, in the surgery world. This is the insufflator, the old insufflator. They put it into a manual cords, and now all optical, and now all like your smartphone. It's easier for me, but it's not that easy for me to teach the other one. Also, our this is the first electrosurgical unit that developed by Vovi, and then next it's like this, and now it's just one big screen, glass cockpit, what you call it, and you can slide and everything like your smartphone. So when I ask my scrub nurse, please increase the wattage, it's not as easy as the old one. You just switch the knob and then make it 40 or make it 50. Nowadays, you have to scroll and then go to page 3 and then and so on and so on. It's not really easy. So what I meant by this one is when you have a new equipment and your surgical team must be trained by the proper team, because you will be concerned with your surgery. You don't really have a lot of time with your equipment. So this is really related with Indonesian Indonesian situation, when they don't really have enough training for the new equipment for the scrub nurse, because I have a lot of trouble with that. So sometimes I have to scrub off and then fix it myself. It's not broken actually, but they just didn't know where to switch and things like that. So you have to make sure in the OR they have really know how to handle with the instrument, and it's better if you have medical engineering department to inspect the equipment and train them. And you should always put user manuals, and then also you have like one small piece of paper or plastic card to summarize what you really want to do. And then all the adapters, attachment, and like if I'm using laser, I have to use some goggles and also some N95 mask, and everything I have to be there. And then as an OBGYN, we have a lot of stress and fatigue, especially the the obstetric department, because they tend to have a lot of unplanned surgery. And then you have to really careful when you are really fatigued, because fatigue will end up a catastrophic result. Mostly is the sleep deprivation can cause error, even in the very small procedure. So is it necessary to limit on your working hours from the hospital point of view, or even your personal point of view, to increase the patient safety? And then in OBGYN department, sometimes when you do a vaginal delivery, they forgot to count. In the OR, in the open surgery C-section, they always count it, but most likely the foreign object left even in the vaginal delivery. So you really have to careful not to neglect to count on the vaginal delivery and also vaginal surgery. And also only use the radio opaque sponge and soft good. You should be placed on the surgical tray, and nobody can touch them, only the scrub nurse. So if you count at the end of the case either incorrect or compromised, then the abdominal or maybe the vaginal examination should be performed. If it's still not matched, then you should perform the radiographic imaging. And then in my hospital, as an academic medical center hospital, we have a lot of teaching. So we have a lot of trainees. Trainees is also sometimes becoming a patient safety issue, and how to deal with that. You have to ask for the attending to be there at all time to supervise, and both the trainee and the attending should be really alert and well rested for the surgery. And especially in the obstetric surgery, the OR is going to be very crowded, because we have the woman, the obstetric surgeon, and the pediatrician, and then sometimes the anesthesiology, and then they have to be a very good communication between the obstetric surgeon and with the pediatrics team. And also distraction, this is quite important, especially in Indonesia. Phone calls, they have 10 people in there, and they have 10 phone calls with playing YouTube and everything. Sometimes it's going to be distracted. So as a lead surgeon, you have to make sure that distraction is kept to a minimum. And you can ask for the non-essential personnel to remain outside while doing the surgery. Okay, as a conclusion, surgical error is in our business, in our world, as a surgeon, is really a serious injury. Even though it's a normal for a human, but we have to admit we are trained to be a superhuman. And then what I would like to ask is to create checklists like in aviation industry, because when you do it over and over again, you all tend to forget something without even realizing it. And then when you have checklists which asked by your team, then you will have less error. And the communication among the members of the surgical team is crucial. So you are not doing the operation alone. You are a team, yeah. And then the technique, new instrument, new technology should be trained very, very nice. And also you have to manage your stress level and fatigue by limiting the working hour. It also can increase the error. And when you educate someone, then you have to be there to train them at all time. Other than that, you might have more error for the patient. Okay, thank you.
Thank you very much, Dr. Hari Nugroho, for your nice presentation. Before we go to the discussion, I would like to invite Dr. Johnny Dharmajaya to deliver the evaluation notes of the presentation, the 3 presentations. Dr. Johnny Dharmajaya, the floor is yours.
Mr. Manopo, ladies and gentlemen, first of all, I will to express my gratitude to all speakers who give scientific experience about patient safety in their experience, in their fields. As a doctor, especially a doctor who works with knife, the issue of patient safety is our focus in work. This is we heard from all speakers that start from Dr. Yopie as a cardiothoracic surgeon, Nigri from logistic surgeon, and Dr. Hari Nugroho from OBGYNs. All of them tell us about patient safety. The similar procedure for patient safety, but specifically Dr. Yopie told us about specific patient safety for cardiothoracic surgery. And I'm amazing that now they have safety checklist very tight than I know. And Dr. Nigri very concerned with the leakage and his sense of anastomosis of colorectal surgery. And then finally, Dr. Hari as an OBGYN, the same with us, give very attention in equipment for operations. Finally, we realize that human, we have a tend to error because human, you said. But as a doctor, we also teach that please do no harm to the patient. So we have do in between. Once again, thank you for very attractive presentation from all speakers. Okay, thank you.
Thank you very much, Dr. Johnny, for the evaluation notes. And now we come to the discussion. It will go in 2 parts. The first is the discussion of the speakers. So each speakers can address the question to the other speaker. Now I would like to give the first opportunity for Dr. Habibie. If you have any question to the other speaker, you can address the question. Time is yours.
Thank you, Dr. Peter Manopo for the great opportunity. Maybe I would like Professor Nigri and Dr. Hari. First to Professor Nigri. In your experience during the colorectal surgery, when you have to perform the anastomosis of the bowel, the small bowel, especially small bowel, and you have the you think that there is a chance that the anastomosis cannot be performed very well, so I have to proceed with the stoma. How do you give the great the information to the patient and to the relatives? Second, to Dr. Hari, that you talk about the minimally invasive with a lot of instruments. In my fields also we do the minimal invasive with VATS and minimal invasive cardiac surgery. How do you train your team that they have to know which instrument should be used for the specific procedure in the OBGY surgery? That's all, Dr. Peter. Thank you.
Yeah. Thank you, Dr. Habibie. Please, Professor Nigri, you can react to this question.
Thank you, Dr. Habibie, for your question. Yes, before any kind of operation, most of the time, before any kind of operation, and especially in emergency surgery, I always say that before to the patient, because the patient has to know that before surgery. Even if it would be a remote possibility to have a stoma, I always say, look, there is this possibility. The stoma may be temporary, so we can close the stoma in a couple of months, 3 months, but always it is important that the patient and the parents or the relatives of the patient know that before surgery. So that's a very important part. We don't want that the patient wake up with a stoma that he didn't know that he was going to have. Thank you for your question.
Thank you, Professor Nigri. Dr. Hari Nugroho, please react to the other question.
Yeah, thank you, Dr. Manopo. So yes, Dr. Yopie, I personally always train my scrub nurse. So maybe every 3 months or every 4 months, and if we have a new scrub nurse, they cannot directly assist me. They have to be trained in-house. In-house means by me, because I'm really like what you call it, perfectionist guy. So I don't want to they destroy my equipment and destroy my surgery in the end. So I really have to ask them to do in-house training every 4 months. Even if the one that already trained by me, they have to be trained again in every 4 months, maybe like that.
Thank you, Dr. Hari Nugroho. Now I would like to provide the opportunity to Professor Nigri. Do you have any question to the other speakers? The time is yours.
I have a question for both of them. The question is just one, but maybe the answer is not so easy. Do you use always the checklist? And if you use it, do you follow all the steps of the checklist?
Yes, please react to this question.
Okay, maybe I'll go first, Professor Nigri.
Yeah.
That is a very, very good question. It really depends. When I'm doing the operation in a hospital that really strict, then I have to do that. Other than that, we cannot do the surgery. But in other hand, there are some hospitals that are not really strict. Even if I ask them to do the checklist, and then they still reject. But I'm trying to do as much as I do.
Okay, thanks.
Thank you, Dr. Hari. Dr. Habibie, do you have any comments on this issue? Dr. Habibie?
Maybe he doesn't hear us.
Okay, I will skip to Dr. Hari Nugroho. Do you have any question to the other speakers? Time
Yes,
is
I
yours.
have one for Professor Nigri and have one for Dr. Yopie. For Professor Nigri, I have a lot of surgery with the GI surgeon, especially when we have ovarian cancer that infiltrating to the rectal. And then most of them, when they do the resection, they always put drain. So I'm really concerned about the drain in your presentation because it's stated that you don't really need that drain, isn't it?
Yeah, you know what? But usually you don't do this solo resection when you have a problem with uterus or ovarian cancer. You don't go so low. If you go low on the anastomosis, you need to use drain. But if you are intraperitoneal, you don't need to use drain most of the time. You know, it was very used a lot in the past, put the drain even in this kind of situation. Today, it's considered a possibility to increase the chance of leakage and dehiscence. So it's better not use the drain if the anastomosis is intraperitoneal.
Okay, thank you.
Thank you, Professor
And
Nigri.
maybe one for Dr. Yopie Habibie. I saw that you have a lot of checklists for the thoracic surgeon. Do you develop your own checklist or that you are using that kind of checklist for your hospital?
Dr. Habibie, please react to this question. Okay, I will skip. Maybe later on he will rejoin again. And now we come to the second part of the discussion with the floor. So, any question from the floor? You can ask directly, or you can, maybe there's some question in the chat box. I have a question to Professor Nigri. Do you have any experience, or maybe you can mention about the conversion rate from the endoscopic surgery into open surgery, maybe by some difficulties, technical difficulties, or other considerations?
You mean in colorectal surgery,
Yes,
right?
in colorectal surgery.
Well, it's something that is, it's modified itself from when laparoscopy has been used in GI surgery and especially in colon surgery. The conversion at the beginning were very high. The rate of conversion was very high. And then the conversion rate is decreasing more and more. And today it depends actually on the experience of the surgeons and the excellence of the center where you're working. Because if, let's say, a surgeon does just 10, 20 rectal resection per year, well, the conversion rate can be very high, meaning that can be 40%, even 40%. Instead, very well experienced surgeons, in the end of very experienced surgeon, the conversion rate is about, it can be 0.1%, 1%. This is actually what is going on today.
Thank you, Professor Nigri, for your explanation.
You're welcome.
Yeah. Any other question from the floor?
Can I?
Sure. Yeah,
Yes,
Dr. Frans.
Professor Nigri, I'm also a GI surgeon, so we perform open and laparoscopic colorectal surgery. So I think one of the factors that contribute to the number of conversion is the case selection. I think perhaps if you push to do laparoscopic, especially in many advanced cases in Indonesia, we have large tumor, bulky tumors. It's more difficult to achieve a 0 point something conversion rate. So perhaps besides the skills of the surgeons, the availability of other modalities like chemotherapy and radiotherapy before neoadjuvant chemoradiotherapy for rectal cancer, it might contribute on the number of conversion rate during the minimal invasive surgery. Now, one question is bothering me about how you explain that that there is a controversy of using bowel preparation before colorectal surgery. I think many of the meta-analysis has shown that it has done more damage than good. But many surgeons, including me, even if I know the fact that doing mechanical bowel preparation is not good, evidence based on the evidence that is available now, but I don't know. Maybe it's about the trust, or maybe it's about the confidence. I don't know. In your center, do they still perform this type bowel preparation? And what is the attitude of the surgeons, the colorectal surgeons, in the bowel preparation? Because sometimes we find that the content of the bowels is because of the difference of the diets. So Indonesian people eat differently, like to the European patients. So the consistency of the content of the bowel is different. I don't know. What is your opinion, and how is it practiced in your center? Thank you very much, Professor Nigri.
Professor
Thank you
Nigri,
for
would
your
you
questions.
Yes,
Thank
please.
you. Very nice questions. First of all, I would like to answer the first one, because you told me about bulky cases of colon cancer. Well, T4 colon cancer actually shouldn't be done laparoscopically. Even in this case, most of the surgeons, it depends from the surgeon's experience, most of the cases. But T4, for example, shouldn't be done laparoscopically. So it's difficult to answer this kind of question. The other thing was about bowel preparation. And it's true, because in the history of bowel preparation and colon surgery, we had different trends. First, it was said that was good to do the preparation, then no, then yes, then no again. So really today there is not an opinion supported by scientific data. For example, in case of laparoscopic surgery, many surgeons don't do the bowel preparation because otherwise you will have liquid content into the bowel, and then you can have contamination when you do the intracorporeal anastomosis. So it's very difficult, and maybe it also depends on the different diets in different ethnicity. Absolutely, that's another point. But at this time, I cannot say yes, you have to do bowel preparation, or no, you have not. I cannot say that supported by scientific data.
Thank you very much.
Thank you, Professor Nigri. Is there any other question from the floor?
Yes.
Doctor, yeah, please. Please introduce yourself. Yeah.
Yes, I'm Dr. Daniel Kokong here in Jos, Nigeria.
Oh, Dr. Daniel, how are you? You come from Nigeria, yeah? Yeah.
Yes, thank you so much for this opportunity, Dr. Peter Manopo.
Yes, thank you.
Yes, I think generally I don't have a question as such, but I just want to contribute to the discussion. I do not want to just take this situation for granted. I want to appreciate the leadership of ICS-Indonesia, especially the president. And I want to appreciate the executive director of ICS, that is Dr. Max Downham, that I see him is participating. I have been participating in ICS Indonesia webinar, which has been very interesting. I listened to the presentations by Professor Nigri, Dr. Nugroho, and Dr. Habibie. Very interesting, very exciting, very informative, and especially in the area of surgical error. Surgical error or medical error is the third commonest cause of mortality and morbidity worldwide. And one of the things that were listed by Dr. Nugroho as well as Habibie, those are facts, especially in large hospitals where you have trainees whom you are training, and then maybe you have some confidence in them, and then you allow them to go and operate without your very presence there. So there are chances of errors. And another area that I want to add to the discussion is the multiplicity of different cadre during surgery. You have the nurses, you have the technicians, you have the surgeon, and then you have other supporting staff. And then especially in emergency situations. So when you have an emergency and then the problem of communication, you can have a distorted communication. And so that is why we did a study here in Nigeria on weight estimation from height in adults that was published in 2018 on resuscitative error. So during emergency, where there is tension, there is stress, as identified by Dr. Nugroho, that once there is stress from sleep deprivation or a long period of duty, so there is, and then you have emergencies. So in such situations, there are situations or there are likely periods that medical errors can result, or also surgical errors. So the checklist is not easily followed because most of the time, if you have an emergency and then your goal that time is to make the patient live. So those are the periods when surgical errors or medical errors do occur. However, one of the conclusions that Nugroho mentioned, as well as Habibie, was the proper communication amongst the surgical team. And then try to, as much as possible, get the checklist being being monitored by a member of the surgical team. Surgical errors or medical by so doing, there is a tendency that the issue of surgical and medical errors will be reduced. So thank you. That is my contribution to the discussion.
Thank you, Dr. Daniel Congo from Nigeria. By the way, what time is it in Nigeria now at the moment?
Yes, our time, my time here is 2:40 p.m.
Okay, thank you.
Indonesia is about 7 hours ahead of us, yes.
Yes. You can adjust your camera position so we can see your face, but at the moment we cannot see your face. Okay. Thank you very much.
All right,
thank you very much, Dr. Daniel. Yeah.
Yes, so Indonesia is about 7 hours ahead of us.
Yeah, from
So,
GMT plus.
Is excellent for us.
Yeah, thank you.
And I like Indonesia because of your president. That's Joko Widodo. Very simple, very straightforward.
Okay, thank you very much.
Interest in Indonesia. Yes, Indonesia because of your, tsunamis, earthquakes, volcanoes. We're usually praying for you.
Yeah. Thank you very much, Dr. Daniel Kokong. Any other question from the floor? I have a question to Dr. Hari, Dr. Hari Nugroho. Nowadays, I think delivery by cesarean section is increasing, isn't it? And if the cesarean section is increasing, what is the indication? Is it a clinical indication or a social indication? Thank you.
That's a very, very good question and on point. Yeah. In Indonesia and in developing country, more and more people are asking for C-section on maternal request. So more and more women are asking for C-section because they don't want to feel the pain, even though we are already asked them to do the epidural in labor, but they still want some pain and don't want any pain, and also they are wanting instant, what you call it. Yeah, but that's not just only in Indonesia, in all developing country and some in developed country. And that's why it gives a lot of problem of the accreta. We have a very high rate of placenta accreta right now due to that C-section.
Thank you, Dr. Hari Nugroho, for the explanation. Any other question from the floor? Maybe one question.
Okay, Mr. Manopo, I have
please.
to Professor Nigri. Talking about bowel preparation for colorectal surgery. In the past, when I was trained, we give on also antibiotics. But now, in era of MDRO, multi-resistant organism, there's some regulation in our country protect said not to give
avoid
antibiotics.
resistance.
Yes, microresistance. What would your opinion?
Yeah, please, Professor Nigri, react to this.
Okay. Very quickly, I don't use bowel preparation usually. I don't do that, and we don't use antibiotics for that. Who use bowel preparation don't use today antibiotics.
Okay.
Thank you, Professor Nigri. Thank you, Dr. Johnny. And now we come to the end of this event. I would like to invite Mr. Max Downham to deliver the evaluation and impression from the head office of the International College of Surgeons. Mr. Max Downham, the floor is yours.
Oh, thank you, Dr. Manopo. Again, I thank you, the speakers, and the leadership of the Indonesian section for conducting these webinars. I think it's simply fantastic. Dr. Kokong and I, and Dr. Kokong in Nigeria and I frequently exchange emails. I'm absolutely delighted, Dr. Kokong, that you are on the line and participating. That's fantastic. Just very briefly, Dr. Manopo, I from a lay person, I jotted down, I took a lot of notes. I think my evaluation, your program is fantastic, and that's kudos to the speakers, all of you, and really, really appreciative. I derived some notes from a layperson, which is who I am, in terms of words that just come to mind. One is focus. One is good communications. One is team, including, I think, perhaps I'm overreaching here, but including the patient is really, in a way, part of the team. I think training, teaching, judgment, fatigue. These are words that I jotted down from a layperson perspective, and they are all words used in management, which is my background, and they all relate in a way, Dr. Manopo and speakers, to another word, which is risk. And risk, of course, is a very big consideration. And of course, the goal is to minimize the risk, to minimize the errors. At the same time, it seems like, in my impression from this, a countervailing thought is that you have more surgeons sometimes involved, you have more and new technology involved, equipment, et cetera. And it's very interesting to me, and I wouldn't expect that to be addressed here at all. But it's interesting if you focus these words on risk. There are some aspects that tend to increase risk, and some that all of you have the goal, of course, to reduce risk and thereby reduce the errors. So a fascinating set of presentations. I'm very honored and privileged to be part of this as a layperson. And I thank you all, and thank you again, Dr. Manopo, and leadership of the Indonesian section. I always say, and I will say one more time, I hope that other ICS sections will do what you are doing in Indonesia. Kudos to you. Thank you very much.
Thank you very much, Mr. Max Downham, for your impression. And now we come to the end of this event. On behalf of the ICS Indonesia section, I would like to express my gratitude to all participants, particularly our guest speaker from the Royal College of Surgeons of England, Professor Giuseppe Nigri, and the other speaker, Dr. Yopie Habibie, Dr. Hari Nugroho, and also for the World President of ICS, Professor Georgios Tsoulfas, Mr. Max Downham, and also from the committee of the Indonesia section, Dr. Johnny Dharmajaya, Professor Hendy Hendarto, Dr. Frans Arifin, and our IT team, Mr. Bimo and Ms. Devi. Thank you very much. And we will meet in the next chapter. Goodbye, everyone, and stay healthy and well. Thank you.
Thank you.
Thank you
you.
very much. Thank you.
Bye-bye.
Bye,
Thank you,
Professor Nigri.
everyone.
Bye.
See
Thank
you
you. Bye-bye.
again.
Thank you.
Thank you.
Bye-bye.
Thank you, Prof.
Thank you.
Yeah, bye-bye.
Thank you, Dr.
Thank you
Hari,
very
Mr.
much.
Max.
Yeah.
Thank you.
Bye.
Thank you. Bye-bye.
Yopie, you look healthy now.
Yes, Dr. Johnny.
Bye
Quite
from my
healthy in
ear.
Aceh.
obese, more obese than I met you last year.
A little bit obese. This
Yes.
is the camera effect. Camera
Okay.
effect. Thank you, Dr. Johnny, Dr.
Thank you
Okay,
Frans,
very
see
much.
you.
Bye-bye.
Dr. Hari semuanya, Dr. Daniel.
Frans,
Thank you.
bagaimana itu
Dr.
kita
Frans, thank you.
web
Ya dok.
web kita gimana nih ceritanya? Saya pengen tahu
Ya
kemajuannya.
itu, ya dok, itu masih dievaluasi sama Mbak Tina itu dok. Kemarin 2 minggu itu sempat
Iya.
ternyata kita langganannya habis, jadi baru
Diperpanjang.
diperpanjang
Ya,
lagi.
penting itu.
Ya.
Sampai sia-sia lah kita bikin, bisa dipakai, mesti useful lah untuk ini.
Ya.
Urusan kita. Oke, next kita cerita.
Ya.
Pamit ya, saya masih ada
Ya dok.
meeting lain
Terima
di
kasih.
kelas.
Terima kasih Dr. Joni. Selamat
Ya.
malam.